We're just getting ready to go, letting a few more people trickle in here. Just give us one moment. Thank you for joining us this evening. And,
Do you want to check the chat box in the Q&A to see if that's working?
yep, those are good, and it looks like it is recording.
Perfect.
Perfect. Slides are looking good.
Great.
All right. I think we're good to get started. Well, welcome everyone. Thank you so much for joining us this evening, this Tuesday evening, cold November Tuesday evening. Thank you for joining us for Men's Health Unfiltered, a new integrative conversation beyond testosterone, presented by Nutrichem. I am Dr. Adam Livingston, PharmD, and I'll be joined this evening by Dr. Yousuf Siddiqui, ND.
Hi, everybody.
Hey guys. So just a quick disclaimer, this webinar is for educational purposes only. Just to give you a brief introduction, I am Dr. Adam, PharmD. I am a clinical pharmacist as well as a compounding pharmacist. I am the Director of Science here at Nutrichem and the Designated Manager of Nutrichem Pharmacy. I work a lot with deprescribing or reducing polypharmacy, so helping patients come off of excessive or harmful medications. I work with a lot of medical cannabis and run our medical cannabis program. I work with a lot of compounded bioidentical hormones for men and women, and a lot of natural health products. I run the Nutrichem supplement line, and I am, with increasing demand and more men seeking out information about men's health, I'm working more and more with men and men's health. I am a husband and a dad. I'm married to a naturopathic doctor with two boys, ages 4 and 7. They drive me crazy, but they are hilarious. I'm never bored. And my philosophy is that of sort of a naturopathic pharmacist. So I like to use the Nutrichem philosophies, which are using things like lifestyle, nutrients, and hormones first, and then bringing in drugs as needed.
And hi, everybody. I'm Dr. Yousuf Siddiqui. I currently serve as the men's health lead at Nutrichem, and I recognize the real gap in high quality, evidence-informed care for men in particular. And I committed myself to filling it. So my training in men's pelvic health, sex therapy, and coaching is fully integrated into my naturopathic practice, which allows me to offer what I call a whole human approach to healthcare. And it's healthcare that considers biology, physiology, behavior, and all together it's integrated rather than looking at everything in isolation. And I'm happy to be joining Adam today, and we welcome all of you to this webinar, and we hope you learn lots. And yeah, we're excited to share our knowledge.
Well, yeah, let's get going. It should be fun. So just to give you a brief overview of what we'll be covering tonight, Yusuf and I are going to talk about the current state of men's health and some of the misinformation about men's health in general and testosterone. We're going to give each of our perspectives on that and what we see here at Nutrichem and some of these conversations we're having. Yusuf's going to give you a really good biology 101 or introduction to the male body, some anatomy, physiology, and the main key players in the hormone cascade in human males. A lot of guys haven't looked at, really examined their bodies or assessed their health since, junior high health class. So that'll be a good little review for everyone. And then we'll get into some of the common men's health conditions as we age, and we'll give each of our perspectives on treatment recommendations in those areas. So it's important to note that this is a really unique and interesting webinar. Just like Nutrichem, we have the pharmaceutical side and the naturopathic medicine side. So we're going to be giving those perspectives and that frame throughout the whole presentation. So we're going to start off with some of the younger guys and covering some of their issues they'll be seeing. And in particular, we're going to hone in on low testosterone pre-andropause, as well as erectile dysfunction pre-andropause. And we'll explain some of those terms as we go. And then we'll really zoom in on cortisol and testosterone and sexual dysfunction, as well as things like drug and alcohol-induced sexual dysfunction and ED. Then we'll move into the older guys over age 40 and talk a little bit about classic andropause and some of the issues and comorbidities that are associated with lower testosterone in aging. And we'll also look at sort of classic age-related ED or erectile dysfunction as well. And then we'll open it up to you guys and try to answer some questions and comments. So, in terms of the current state of men's health, what I see a little bit more on the pharmacy side, and some of these are men coming in, they're wanting to speak with a healthcare provider. They're basically jumping right to seeking TRT or testosterone replacement therapy based on a feel or an age or a small handful of symptoms. There's a lot of self-diagnosing going on without discussing anything with the healthcare provider. They want to jump right to the TRT or the Cialis or the Viagra, some of these sort of heavier duty options before looking at optimizing their lifestyle and what's going on in their life, which is more critical for overall men's health first before we get into discussing using any kind of external testosterone options. It's important to note though, and I have to, remind guys of this and slow them down a little bit when they first come in all, excited to look at testosterone, that the actual eligibility, the clinical criteria for low T, the actual number of men that would qualify is a lot lower than this demand. So most men who are seeking TRT and sort of jumping the gun in this way, they don't actually need testosterone replacement therapy. And there's a lot of options before that. And what we see, and why is there this gap between the demand and the actual need for testosterone replacement? There's a lot of aggressive marketing and social media influence on this, and a lot of these guys are not experts. There's a lot of like pseudoscience-y stuff going on out there. And a lot of them are actually abusing testosterone in ways that is not how we would do it on the medical side. There's a misinterpretation of symptoms as low testosterone. So things like fatigue, low mood, insomnia, and poor sleep. A lot of them are going, "Yep, it must be my testosterone," which is again is often incorrect. And there's a lack of standardized testing and protocols in some of these areas. Some of these private clinics that are, men's health clinics, but they're really just sort of pumping out things like testosterone, hair loss options, and PD5 inhibitors like Viagra, Cialis, and some of these erection medications, and not really doing sound like holistic men's health practices. And there's data to reinforce this. Only about a third, between 20 and 40% of men seeking testosterone directly would actually meet the diagnostic criteria for low testosterone or andropause. And this includes older men. It's not a guarantee that older men even need to go on TRT. So my message really just to, put it all together is really that testosterone is a hormonal health tool, not the goal.
And in my work as a naturopathic doctor, um, who's focused on sexual reproductive health and a branch of it in men's health, one of the frustrating things that I see and hear, and Adam spoke to this, are the limited spaces for real discussions pertaining to men's health. So, for example, those men's health clinics that are toting themselves as men's health clinics, but really they're just focused on testosterone. And the problem with that is that men tend to favor problematic problem solving and quick fixes. And the premise of naturopathic medicine is to get to the root cause. It's where we're looking at the entire human. And I don't think there are a lot of spaces for men to have those uncomfortable conversations and to get and to seek comprehensive care. I also notice, and Adam talked to this again. You're going to hear there's a lot of some similarities in what we're talking about, but there's inconsistent and potentially harmful resources, and that's a lot of social media, fitness influencers who are employing pseudoscience and anecdotal information. And that could be to sell products. That could be who knows what it is they're trying to do. But it's really seeding this element of body dysmorphia that we've seen in females, unfortunately, and now we're starting to see it into men, and there's a lot of misinformation. The next 2 points in the slide really talk to that increased isolation and retreat. And that's layered in with what is modern masculinity. And this really ties into my work in comprehensive men's health. In my practice, I observe that a lot of guys are retreating into gaming, pornography, alcohol, substance abuse, AI engagement. They're really pulling back from the world because we haven't actually defined what masculinity is. And even in the men's group circles that I'm in, and some of them international, there seems to be this confusion as to the roles that we play as men. And this for sure plays a role into how we show up in terms of
Mm,
our health. The next slide, we're going to talk about all things anatomical. So we're going to look at we're going to focus on the left slide. So Adam, if you wouldn't mind moving the cursor over the
yep.
bladder. And so welcome to your anatomy. The bladder is this, as Adam circling around it, fills with urine. And then when the bladder is full, urine, of course, passes through the urethra, ureter, down through the penis, and then you pee. In men's health in Movember, what we really should be talking about are the changes that start to happen when the prostate starts to enlarge. So as you can see, the ureter passes through the bladder, and when the prostate starts to enlarge, it starts to impinge or narrow that tube. And as a result, we'll start noticing that when we're peeing, we're dripping more than we did before. It's no longer shake, shake, done. It's shake, 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 squeeze, done. You'll start noticing that you'll have intermittent urination. So you'll pee, you'll go wash your hands, then you got to pee again. You'll start noticing a stain in your underwear. That's when we start looking directly at prostate health in men's health. On the diagram, Adam, if you could circle around the testicle. So when
Mhm.
you do your self-testicular exams, what you'll notice is there's a spongy tissue attached to your testicle, and that's your epididymis. In your testicle itself, that's where we make testosterone and, of course, sperm. Sperm mixes with semen in the epididymis. It travels through the spermatic cord, wraps around your bladder, and then if you come back to the prostate, you'll see there's this seminal vesicle where more semen is made. It passes through the prostate, and then we have what's called an ejaculatory reflex. That's that pumping sensation that occurs when we're ejaculating. So we start to notice a change in the volume of ejaculate, the color, the consistency, as well as that the strength of that pumping action. That starts to, as a clinician, make me curious about prostate health. And when we're talking about prostate health, um, and hormone health for that matter, Adam, if we move to the next slide, we start looking at male hormones and the male hormone cascade. So this is pretty nuanced, and I'm going to try to keep it fairly high level. We have GnRH, which is a signal from the hypothalamus. It tells our brain, the anterior pituitary in our brain, to make luteinizing hormone and follicular stimulating hormone. That is essentially like a dial to tells our testicles to make testosterone. So for example, if luteinizing hormone is really high, it means that the Leydig cells in your testicles aren't making enough testosterone, and your brain is yelling at your testicles, make testosterone. And so we use that as a tool to figure out what exactly is going on in the testicles. There's different types of testosterone. You probably read about them. There's total testosterone, free testosterone, dihydrotestosterone. Free testosterone representing about 1 to 5%. That's the testosterone your body is actively using. So that will affect things like mood, motivation, libido, muscle strength, bone health. Total testosterone is your entire testosterone, and then dihydrotestosterone represents about 10% of your testosterone. When dihydrotestosterone gets too high, the receptors on our scalp and on our prostates proliferate, they expand, and that's when we start getting prostate enlargement and our hair starts to fall out. Um, on the other side, in my blood work, I test estrogen, estradiol in all men. And the reason why is that as we age, or if we're developing what's called metabolic syndrome, we're putting on weight, or we're getting some insulin resistance, cholesterol's going up, our body's naturally going to shunt our testosterone into estrogen. When estrogen gets higher in our body, that's when, as a male, we start experiencing water retention. We want to hug more than we want to have sex. Our libido starts to drop, gynecomastia starts to set in, and a lot of men will describe when their estrogen is higher than their testosterone that their penis they look down and they're like, my penis looks like it's pulled in. It doesn't look as like full or girthy as long as it used to be. All of a sudden, it's feeling a bit retracted. that's pointing in the direction of, okay, let's look at what if testosterone is shunting through to estrogen and aromatase. So the complexities of the of the male hormone cascade isn't as complex, obviously, as females, but it does have its nuances, and it's important when we're looking at reproductive sexual health for male to have all factors tested. Adam, if we move to the next slide, perfect, thank you. Is we have here's some kind of sampling of hormones. So we have low free testosterone with elevated sex hormone binding globulin. So in this case, the bioactive form of testosterone is low, and sex hormone, which is a protein binding globulin, is elevated. And this is when we start seeing that men have that like classic low testosterone, fatigue, mental sluggishness, depression. High estrogen, I covered that a second ago. That's where we have like abdominal weight gain, muscle loss, and that turtling of the penis. Elevated luteinizing hormone, follicular stimulating hormone. Again, it just means that your testicles aren't making enough testosterone, and there's great naturopathic interventions in that space. And then elevated cortisol, we're going to talk about in quite a bit of detail in the subsequent. But these guys who are wired but tired. These are these guys that are managing a lot at home, relationship, work stressors. They're on the verge of burnout if they're not burnt out already. And there's a lot of interventions for us to discuss in that space.
Great. That was a perfect rundown, Yousuf, a good intro. And then if we sort of, Yousuf's getting into the clinical and all this amazing, testing side of things. But if we sort of zoom out and look at male testosterone levels throughout life, and sort of generalizing here, but looking at average levels, we can see that that testosterone level essentially peaks right around puberty. And then we get this gradual decline throughout life with a bit more increased decline around age 40 to 60. And that's our andropause period for men. It's not exactly the same, but it's sort of the male menopause. And it does refer to this gradual decline in testosterone and other androgen hormones in men as we age. And unlike female menopause, which occurs more abruptly around age 50 in most women, of course, with exceptions, andropause develops more slowly, typically starting around 40 or into the 40s, late 40s to early 50s, with testosterone levels dropping about 1% a year after age, but in your 30s typically is where you get this decline starting. The medical term often that you might also hear used is late onset hypogonadism or androgen deficiency in the aging male. It's also important to note that unlike female menopause, andropause does not result in a cessation of reproductive function. So sperm production usually continues into late life, although sperm quality, count, motility, things like that tend to decline. But men are still essentially fertile and can reproduce later into life, as we know. And that is because we get this, sort of gradual decline, but not a shutting off of the hormones. And for the sake of this presentation, and it's a little bit arbitrary, Yousuf and I decided to split it about age 40 for pre-andropause versus, andropause or so gentlemen that are in sort of the pre-andropausal window where they haven't experienced this sort of increased decline in testosterone versus where men are kind of in this andropausal window. And I think as healthcare providers, the reason we sort of divided it this way is because if I have a man coming in under age 40 and he's having, suspecting low testosterone, a diagnosis of low testosterone, or having issues with ED or erectile dysfunction, it might set off a little bit more of a bit of a red flag in terms of what's going on in this guy's life, because that's a little more abnormal, for example. Whereas over 40, we get into the andropausal zone, which Yousuf can speak to.
Hmm. And it's interesting as we start to age, what we call comorbidities or comorbidities it's multifactorial. So in the male body, what'll happen is as testosterone levels decrease, we see an increase in cardiovascular and metabolic disease. So metabolic disease being diabetes, high cholesterol, central obesity. So we're starting to develop more belly fat. But at the same time, what's important to note is that central obesity, type 2 diabetes, insulin resistant will also decrease testosterone. So when we're unpacking an individual, meaning like we're completing comprehensive assessments, we start to really dig into the weeds as to how they arrived in that session.
Mhm.
Of course, classic andropause comorbidity would be osteoporosis and sarcopenia, which is bone loss, muscle loss, and then mental health disorders with low testosterone. Those are the guys that are on the couch, sleeping, disengaged from their relationship, frustrated with their kids, frustrated with work. It's important to note as a clinician that sometimes anxiety and depression will lead to behaviors that contribute to low testosterone. So when we're really
Mhm.
looking at the individual, we have to address all of these types of things. And these things don't exist. It's in the male body, it's a continuum. So 40 isn't the cutoff. Sometimes these things affect men later in life. Sometimes they affect men earlier in life. We just chose 40 as a way of just delineating between the two.
Yeah, and I really like that you clarified that sort of bi-directional relationship where, yes, as we age, generally testosterone for men is going to decline, and it does lead to things like, worsening cardiovascular health, musculoskeletal problems, maybe some mental health issues. But as you said, it's also bi-directional in that mental health issues, musculoskeletal disorders, or cardiovascular metabolic problems also can contribute to the lowering of testosterone, right? That's a great point.
Thanks. I think the next slide mine, I think. Nope, yours.
Yeah, just introducing. Okay, so we are going to move into the pre-andropausal realm. So these are guys under 40, and we'll talk about testosterone and erectile dysfunction.
Mhm. So, what are the symptoms of low testosterone? I'm sure a lot of us are aware of it. For me, as a in my clinical work, reduced libido, low sex drive, I would say is an indicator. It's not directly associated with low testosterone. There are more complexities to that. The reduced morning erections, I would say, is a fairly good sign that testosterone should be assessed. Difficulty achieving and maintaining erections is multifactorial. Yes, low testosterone, but pelvic floor issues can arise, relationship issues can arise. Loss of muscle mass, gain of body fat, yeah, testosterone for sure. Irritability, fatigue for sure. Depressed mood, again, multifactorial, but we can't ignore testosterone as well as low motivation. And the little image that you have on the right side, I love the reduced shoulder mass, increased belly fat, and inconsistent erections or ED. All signs to get your levels checked.
Yes. I feel like as I'm aging and, fighting the dad bod per se, I feel like I'm looking more and more like that guy. So all the more reason to, get our health ducks in order.
And what are the causes of low testosterone in a male under the age of 40? There's genetic conditions like Klinefelter syndrome, which surprising in my practice as a naturopathic doctor, I've diagnosed in a few 30-year-old men, which is wild. It points to the need for us to be doing comprehensive testing and hormone testing in all men. Testicular injury, so undescended testicles or testicular torsion in childhood, or a physical injury can impair testosterone production. Pituitary and hypothalamic problems typically are diagnosed at a younger age. I don't really see that in my practice. But again, the most common, and you're going to hear us talking about this over and over and over again, poor sleep, chronic stress, sedentary lifestyle, heavy alcohol use, drug use, including opioids and steroids, overtraining. As men, we're like, I'm turning into a dad bod. I need to get to the gym. I got to lift weights. I got to watch my calories. And we push, 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 push. And we're actually doing ourselves a disservice. Because what we're doing in that overtraining is we're pushing ourselves into cortisol, a cortisol overdrive, which kills our testosterone even more. My marathon runner patients, they don't have any testosterone. They live fully in cortisol. It's wild to see their blood work.
Mm.
And then I'm going on a tangent. And then last of all,
A
there's
good
severe
tangent.
caloric restriction. Yeah, severe caloric restriction. So that's like cutting. So the weightlifting guys who are competing, the consequence of doing severe caloric restriction is that they become more dependent on testosterone if they're injecting.
Mm.
Hmm.
So let's move to some of our treatment recommendations then, Yusuf, for
Hmm.
low testosterone in the man under 40. I can give some insights of what I like to recommend and what I like to dig into with some of these patients. Um, first line, we're going to look at lifestyle and we're going to look at is there any testing or a diagnosis. As I said before, some of these guys are coming in, oh, I need testosterone. Like you said, men are very solutions focused. So they think, oh, this must be the problem. Here's the solution. Boom, I want testosterone, doc. Like, let's go. We need to see, is there actually testing? Should we get to send them to someone to requisition testing? We prefer to test and not guess or self-diagnose. We're going to look at sleep, and some big areas to look at are going through an average night with these guys, working on sleep hygiene, and then also ruling out things like sleep apnea, which is often overlooked. We need to look at stress management. I really recommend or try to get guys doing resistance training multiple times a week. That can be really vital for testosterone. Removing things like drugs and alcohol, those are both great ways to dampen your overall health as well as testosterone. And then looking at diet, are they overeating, undereating in terms of macronutrients? Is their is their diet high enough in protein to control blood sugar and maintain muscle mass? Are they getting healthy fats and things? A lot of people are against cholesterol, but you need cholesterol and some fats to make steroid hormones like testosterone. And another one we see sometimes is not going too low on the carbs, low carbohydrate diets. And, I used to be a keto guy, low carbohydrate guy. It can really shock your testosterone going too low on the carbs. It can be hard on the body. So that's something I like to probe into as well. A lot of these, I call them almost foundational supplements for men. I recommend, I really like, there's a supplement called ZMA. I don't love all parts of that, but that was a very famous men's testosterone, building block supplement for a long time. But I love zinc for men. It's probably my favorite mineral for men, especially like a zinc glycinate, very absorbable. Magnesium glycinate or bisglycinate, I recommend to almost anyone. Everyone should take magnesium, almost everyone. Aspartic acid, again, not very great evidence for actually working. It's in a lot of supplements for testosterone, but I put meh there in that it doesn't show much clinically to actually work. B vitamins, namely like B6 or activated B6, P5P. Vitamin D3, really important here in Canada. And then there's some others like boron, and I also really like omega-3 fatty acids for reducing inflammation and cortisol and helping with this as well. Yusuf can speak more to the botanicals. Number one that you'll see popping up over and over on Yusuf and my side, I think, is probably ashwagandha. Ashwagandha probably has the best clinical research for helping to reduce cortisol and increase free testosterone. And Tomcat Ali is not bad either. Things like fenugreek, horny goatweed, despite the name horny goatweed, both of those do not have great evidence, and I haven't really seen them work for men very well. In this population, I'm always hesitant, but if we can optimize all of these things, use the supplements, use the botanicals, and there's still issues, I may end up working with the prescriber and making a recommendation to start them on like a low dose TRT, where we could look at like androgel or a compounded testosterone cream. We compound a lot of testosterone creams here at Nutrichem, and I also really, and they have their place. I know Yusuf doesn't like the creams as much, but even going to a low dose of even an IM injection of one of the testosterones as well could be an option if we work through, our first three lines. It's on the table, but often not necessary.
And thanks, Adam. And you're going to see there's a lot of overlap. In my work as a clinician, my starting point across the board is I will requisition the blood work that falls within my scope as a naturopathic doctor. And in that, we check the hormones. We immediately evaluate the hormone cascades that I had mentioned earlier. There's a mental health check-in and a physical if applicable. And basically, what we're doing that initial set is we're baselining it. We're trying to figure out where are you at, where have you come from, and where are you at today. My first line, I call this foundational, and this is really aligned with what Adam was talking about. If sleep apnea is present, sleep apnea is a testosterone killer. I'll requisition a home sleep apnea test. You do it one night, I get the results 3 days later. If you go through OHIP, it's 14 months. And that's such a barrier for so many men. My approach is first to fill the gas tank. Like, let's start building the foundation. In a male that's say 45 and younger, I'm confident that his testicles can start making more testosterone once we figure out exactly what those barriers are. And we do that through the comprehensive assessment. Once we figure it out, then of course we move to ashwagandha, shilajit, zinc, plant sterol, saw palmetto, and lycopene for dihydrotestosterone. We're lowering estrogen with DIM, calcium D, glucarate, and boron. So there's lots of options, and then we start testing. So the other thing that I do is like, is it working? Because at the end of the day, we can throw 100 supplements at you, but if they're not doing anything, then we have to pivot or dig a little bit deeper. Which is why I have my fourth line as in a male under the age of 45, even 50, I'm hesitant with TRT. And as Adam had mentioned before, I prefer injection over topical. The main reason being is androgel has a high likelihood of shunting into estrogen. So the moment we start on androgel, what quickly follows is some sort of an aromatase inhibitor to keep the testosterone at testosterone. Where testosterone that's injected tends to stay as testosterone a little bit better. We also need to note that in a male who's 40, 45, once we start testosterone replacement therapy, it starts to there's infertilities on the table, testicular atrophy, so shrinking of your testicles. There are protocols to get your testicles to start making testosterone again on its own, and it does work. But you're putting a lot of strain on your anatomy when there are naturopathic, tried and true interventions that work well, and you're restoring the natural functions of the body. This is me again. So, erectile dysfunction. So, a lot of guys coming into my practice are coming in for ED. I'm one of, I think, I don't know any other naturopath who has a focus in men's health the same way that I do. And what's important in this space is we start to delineate sexual health from men. And I need 1 second to pull up my thing here. So when we're looking at pre-andropausal erectile dysfunction, for me, there's a sexual dysfunction component, which is a broad term that refers to any problem that prevents an individual from experiencing satisfaction during sexual activity. So that could be anything. That's like a catch-all phrase. Broken down into desire, arousal, orgasm, and pain. Erectile dysfunction in itself is broken down into two categories, the psychogenic erectile dysfunction and physical erectile dysfunction. And when we're working through the assessment process, what I'm doing, I might be asking you some pretty odd questions, but I'm trying to figure out where we're at. And so from the psychogenic side, what we're looking at is relationships, body image, confidence. The number one thing is fear of losing an erection. Any male who's lost his erection one, two, or three times, the movie starts playing. When he steps up to bat, he's going to say, is it going to happen or is it not? And the moment he says to him, asks himself, am I going to get an erection? His nervous system shifts into a fight or flight, sympathetic nervous system overdrive. And as a result, blood flow moves away from his penis into his heart that starts pounding, and he loses his erection. Across the board, any male that comes into my practice, we have this conversation because I think it's important. Another thing that's important to us is how we feel in our body, back to the psychogenic component. I have male patients who have Crohn's colitis, and they're like, hey, look, when I've got a flare, an ongoing flare, last thing I want to do is have sex. And there's pressure that they're getting from their spouse. And we have to remember we have feelings too as men. And then there's a physical ED, and that's where we're going to dive into that a little bit more. But that's cardiovascular, so blood flow, metabolic, so diabetes, pelvic floor dysfunction, which I'm not going to go into a ton of detail, but that's when men, I notice they have pelvic pain, or when they lose their erection when they're changing positions. That's a good sign that there's probably a pelvic floor issue. Low testosterone, and then Adam's going to talk extensively about the medication side effects as well. The next phase is what are the causes? So I'm going to whip through this really quickly, except for a couple. So
Yeah.
Peyronie's disease is interesting. It's rare, but even in my practice as a naturopathic doctor, and this attests to the fact that men are getting physicals, but Peyronie's disease has to do with the curvature of the penis, and that can be either due to a trauma to the penis, so scar tissue develops within the shaft of the penis, or it could be directly related to cardiovascular risk. And there's some really interesting studies that look at men who have onset of Peyronie's in the absence of a trauma have I can't remember the percentage, I'm terrible with numbers, but an increased risk of a cardiovascular event within the next 1 to 2 years. So when that shows up in my practice, it's an immediate letter to their family doctor to get a referral to a cardiologist for a workup. So it's important to remember these risk factors. Um, Pre-andropausal ED risk factors, psychological, of course, of performance anxiety. I spoke about depression, anxiety, SSRIs worsen erectile dysfunction. Again, Adam's going to talk to that in a couple of seconds. We all are aware of that porn doesn't have a great um, benefit to a human sexual relationship. Smoking, vaping, alcohol, recreational drugs, sleep, and chronic stress again. And then metabolic disorders. So, pre-diabetes, insulin resistance, getting your fasting blood insulin tested is such a key thing when we're looking in the longevity space, especially in men's health. And then I'm going to pass it actually to Adam, who's going to talk more about the medication and hormone imbalances.
Yeah, and I'll go into that was great, Yusuf. Thank you. I'll go a little bit more in depth when we get into drug-induced ED and sort of focus in a little bit more. But I just wanted to note here, these have like a very high rate of causing ED when patients are on them, especially antidepressants like SSRIs or SNRIs. These are sort of classic antidepressants like your Prozac, and some of those that you've heard of. So most commonly patients, we need to explore that if they're on one of those medications, especially in men. Like probably 40 to 50% of men I talk to on an SSRI have some amount of erectile dysfunction, some severity. Sometimes it's more mild, sometimes it's quite severe, and it does lower libido as well. Another interesting one that's in the men's health realm, and a lot of guys use it, are things like finasteride or dutasteride, which can help inhibit DHT, and orally they can wreak havoc on libido and sexual, functioning for men. So a lot of, when we compound some of these, they're used topically and just placed on the scalp for hair loss. Yusuf and I were kind of joking when we were preparing for this webinar of it's sort of the opposite. It's sort of a paradox. You're getting the hair back using this, topical localized thing and thinking, oh, it's just local. It's not absorbing and causing these effects for like ED and testosterone, but you do absorb some of it. So now you've got the hair, but you can't have sex. So it's a little bit of a paradoxical, cruel joke for men. So just something to keep
And
in
it's
mind.
interesting
Yeah.
to jump in. It's
Yeah.
interesting because that my patients will describe it as dead dick. And then I
Yeah.
look at their intake form, we'll see finasterides, and we
Hmm.
check their dihydrotestosterone and it's low. And it
Yeah.
takes a while to bring this back online again.
Yeah, so that's very common as well. Psychostimulants, there's a lot more adult diagnosis of like ADD now, and there's a lot more use of essentially amphetamines or stimulant class medications. These medications actually can drive up libido. They're very dopaminergic. They are like amphetamine or stimulant class medications. So they drive up libido with the dopamine, but they reduce blood flow. So a lot of these men may have a high libido and then they can't get blood flow. So they cannot get hard, essentially. So it's again a bit of a cruel joke of driving up the libido and then you can't use your penis. So that's a pretty common complaint I talk to with men taking ADHD medications. And then the next couple are really antihypertensives, so blood pressure medications. We see these stacked in older men in particular, some younger guys, but those can really wreak havoc on blood flow and they can also cause ED. And then things like opioids mess with what's called the HPA axis, so they can basically shut down hormones. And then benzodiazepines, one of my least favorite classes of drugs, quite dangerous. I deprescribe a lot of people off of those. They can also, do things like reducing testosterone and causing erectile dysfunction as well.
Mhm.
So I'll jump in on this one, and this is a huge topic, and especially in men under 40. Where generally, as Yusuf was saying, they, in theory, should be able to produce their own testosterone. Like they may not be producing much now, but we can use things like supplements and treatment, protocols to try to get as much testosterone as possible, right? Get their testicles back online, get their testosterone leveled up. The biggest robber in these some of these men is cortisol, the stress hormone cortisol. So, and the biggest way, the best ways to crank up your cortisol and reduce your like testosterone is to kind of burn the candle at both ends. So, working all the time, really high stress, and then you're not sleeping, your cortisol, I can highlight it here with my cursor, your cortisol, like poor sleep and high stress is going to lead to a big increase in cortisol. Your body makes cortisol when it thinks that there's a threat. You go into fight or flight mode, it releases cortisol to get ready for some kind of chronic stress. It's like you're in a war zone or something. Your brain, your hormone cascade thinks you're in this stressful sort of war zone. It ups the cortisol because that can help. It's a natural anti-inflammatory, so it has benefits. It's a survival mechanism. But over time, that chronic stress and poor sleep overall leads to much lower total testosterone, and it increases sex hormone binding globulin, which comes in and basically binds up that free testosterone. So now your testosterone is not free to go and hit cellular targets to do its work, to increase muscle, to increase bone, to make you feel better, to make you feel confident, to make you have an erection. So higher cortisol leads to lower total testosterone and lower free testosterone. Essentially, cortisol hijacks our testosterone. It's the biggest robber of testosterone, especially in the modern world. So we really wanted to highlight it here. And on the sort of classical Western medicine side, this is often overlooked. And this is a huge
Mhm.
factor on lifestyle. It's a huge factor with men's health, especially sleep. We often talk about, men's mental health issues. A lot of them are related to sleep. So that's where Yusuf and I are just really harping on this. Anything else on cortisol,
Mhm.
Yusuf? We could talk about it
Uh,
all day.
I could talk about it. Actually, if we move to the next slide, I can talk about
Yeah.
like the naturopathic
Yep.
interventions
Yep.
for
Kick us off.
cortisol because this is
Yep.
where we kind of move in different directions from a pharmacist, a little bit from a pharmacist to a naturopath. So for me, my work in executive coaching and trauma healing and coaching is really into this space because I endeavor to train in this space because how do we help individuals create more balance within their life? And so in my baseline, I wrote check in on home and work dynamics. What's draining you? And to have
Mhm.
those conversations because that's root cause. Because if there's misalignment in the day to day, how do you fill your cup up?
Mhm.
Right? I also added in requisition home sleep study again and sex hormone blood testing, of course, including a serum cortisol for baseline. Not the best test, but it just gives me an idea. My first line, which is similar to what you have, Adam, sleep and hygiene, circadian rhythm optimization, which basically means your sleep-wake cycle. Ashwagandha shows itself again. Mindset executive coaching, strategic and gradual workouts. This goes back to what I was talking about earlier in individuals who are on the verge of burnout or burnout, they're gonna they're gonna like flatline themselves. And then a high
Mhm.
protein diet. Cortisol lowering supplements, phosphatidylserine, magnesium, B5, B6, L-theanine, glycine. I added in beetroot just as a vasodilator for better quality erections. And then as a naturopath, what's interesting is that the tools that I use when someone's in burnout or on the verge of burnout goes to a third line, which is adding in a prescription for desiccated adrenals. That allows the adrenal gland that sits on top of the kidneys a little bit of a vacation, and we're adding in some exogenous hormone. and intravenous therapy. I run the IV clinic thing. And then the and then the fourth line for me would be four-point cortisol testing. So none of this is working and burnout's still on the table. What I want to do is evaluate the metabolites of cortisol and cortisone because that's going to give me an indication as to what is going on from that stress hormone perspective.
Hmm. Yeah, and then on the pharmacist side, some overlap. I would say I would jump a little bit quicker just to symptom management, classic pharmacist, but safe options here. So again, I'm going to go through lifestyle. Sleep and stress are going to be the big factors. If the stress is getting into full on, you know, burnout or anxiety disorder, that's where we might, I might do a referral to a therapist to work on some of that as well. And then in terms of supplements that are quite safe, that can give you the vasodilating effect and sort of give you a bang for your buck relatively quickly. I do often recommend things like L-arginine, so these nitric oxide producing amino acids like arginine and citrulline. And there's a variation in those doses, but those can be quite helpful for some men. They're almost like mild versions of Viagra or Cialis. Beetroot, sort of same idea. I don't use it as much. And then, of course, good old-fashioned ashwagandha, and a couple others there like theanine and glycine. But ashwagandha so to sort of get at the cortisol as the root cause, but then treating the symptom of vasodilation with arginine or citrulline, I find pretty effective. Still going to look at the foundational vitamins, minerals that we use for building testosterone with men, and those are good for general health anyway. So I'd be playing around with those with this patient. And this is actually where, although, it's a guy's under 40, we can probably, get him to a point where we don't need medications. This is where I'd still be relatively open because they're safe. PDE5 inhibitors in general, yes, they're a drug. Guys sometimes are like, oh, I want to go all natural. I don't want to use a drug. But things like sildenafil and tadalafil, Viagra, Cialis, you've heard of them, especially at low doses, very safe. Unless you have a cardiovascular issue or you've had like a cardiovascular event recently and you're on something like nitrates post heart attack, they're basically
Mhm.
safe for most of the population. And they're becoming easier and easier to get for a reason, but they still have their dangers. But I would be open to that sort of last line if the other stuff's not working.
I think that's at the end of the day, our sex life and our is important.
Exactly.
So
It's
opposed to
it's
it.
what's the risk benefit of no sex life versus, oh, I had to take a drug. Well, there's a reason they're blockbuster drugs. They're pretty darn safe and they are effective. So
They're not always well tolerated, but they're mostly well
yeah.
tolerated.
Oh, Yousuf, you want to
Oh,
zoom in on this
the
one?
performance anxiety. So this kind of starts drawing on my training in sex therapy. And I think this is a really important discussion to have with men. Because in my practice, I'll notice clinical presentations of men who are avoiding conversations about reproductive sexual health, or they're talking about avoiding intimacy. They're having difficulty initiating or maintaining erections. They have anxiety before sex. And there's this recurring thought process of what if I can't? And the problem with what if I can often leads to not being able to. And so it's important for us to talk about how stress plays a role in our sexual performance. And with men, there's a psychological component of perfectionism, fear of failure. We can see that stress and physiology and the sympathetic activation. We look at polyvagal theory. We move out of the ventral vagal into the sympathetic nervous system. It just shuts down our sex drive. Relationship factors is huge, really huge. It's, the person that you're intimate with and the dynamics that are there, the dynamics that you have within yourself play an important role in that anxiety. I mean, is your spouse supportive of what you're going through? Are you disclosing to your spouse what you're personally going through? Sociocultural pressures, of course, unrealistic expectations, pornography, social media. Adam and I were talking about peers, and that a lot of men will overestimate their performance amongst other men,
Every
and
guy
that can
thinks
be
they're
quite
great in
toxic
bed.
as
They think
well.
they're the best in the world. Every guy,
Yeah, or
or they like to
they'll
brag.
inflate whatever it is that they're describing, and it
Mm.
creates this competitive nature. Instead of talking about the vulnerability side, they talk about their strength, and we're socialized into this. Or
Mm.
so the importance of men's health is finding spaces to have the uncomfortable conversations.
Mhm.
And I think that's really important. Thanks.
Yeah, that was great. I won't spend too much time on this because I'm hoping most of you guys out there know this, but alcohol can wreak havoc on your sexual functioning and testosterone in general. Short term, even binge drinking. Most guys know this if they've binge drank before. It can definitely impact blood flow, and that's what we call sort of might be a crude term, but like whiskey dick. That's what it is acutely when you consume a lot of alcohol, and binge drinking has a lot of risks. And one of them is things like sexual dysfunction and ED. Chronic alcohol use is probably one of the worst things for your overall health, period. But it does lower testosterone, cause ED by damaging nerves and impairing blood flow. And a lot of men, this is a big factor that we have to look at. And it creeps up on you, right? Guys are, oh, it's just a couple beers, a couple times a week. But then before you know it, you're having, for no real reason, not a special occasion, you're having multiple drinks every night, and it becomes sort of problematic drinking, and erectile dysfunction can happen. So it's important to note that, and it's always something that we assess when we're talking to these guys. We won't spend too much time here, but it's important to know that if we look at, we move from alcohol-induced ED to drug-induced, it's basically where a drug is impairing some metabolic pathway that then can affect like your erectile functioning. So some drugs like blood pressure meds can affect blood flow and cause ED. Some drugs like the dutasteride or finasteride for hair loss that I mentioned can actually reduce things like DHT and drive down libido, lower testosterone and cause ED. Some antidepressants like SSRIs very commonly. So serotonin is increased. Serotonin can help you with mood. It makes you feel joyful. But if we look at the brain, and this is overly simplified, serotonin is sort of the joy, the happiness, the antidepressant, but dopamine is reward and libido. So high serotonin often can lead to that sort of reduced libido, and that can lead to the reduced desire and things like erectile dysfunction. And then sedatives. Sedatives basically dampen the nervous system's ability to get aroused. And there's all kinds of sedative medications that can cause erectile dysfunction.
Hmm.
Some of the most common drugs that cause sexual dysfunction in ED, again, we've talked about antidepressants, even the old school tricyclics that people use for sleep can cause this. Antipsychotics, again, a bit less common, but even off-label medications like quetiapine, 25 milligrams, Seroquel's used off-label for sleep. I have seen that be a bit of a culprit for ED for some guys. Um, again, blood pressure medications on blood flow, antiandrogens we talked about. And the other one that I just wanted to highlight because I see it more and more are those ADHD meds, which are psychostimulants. They're often in the amphetamine class, and they can drive up, sex drive, but they can really reduce blood flow and cause erectile dysfunction. A lot of illicit or recreational drugs can certainly cause erectile dysfunction. Alcohol, cocaine, and amphetamines and opioids are definitely the biggest of note there. Of like, those cause problems like lower testosterone and erectile dysfunction. I wanted to highlight just quickly cannabis, which has very mixed reviews on sexual function, fertility, and testosterone. You'll see studies come out saying, oh, using too much cannabis drops testosterone. It can make you infertile. You should stop cannabis if you're trying to get, you and your partner are trying to get pregnant. Um, in general, mild or sort of low to moderate use of cannabis, especially if you're not smoking it, more going to like, it's not great, but vaping or edibles is certainly better for fertility and your hormones. Smoking is a big risk factor. So even with these guys that, maybe they do have a bit of a cannabis use disorder, or they're not willing to give it up, we can at least do harm reduction and get rid of the cardiovascular risk factors of smoking and eventually move to edibles. And I see a lot less issues with testosterone and fertility if you use sort of those safer forms of cannabis versus like smoking cannabis all day. And again, extreme use of any of these is not going to be good for your general health or your sexual function.
Hmm.
Yusuf, did you want to jump in on the naturopathic
I do.
treatment approach
So
here? Yeah.
one of the amazing things um, that I love about our clinic is that we have these areas of it's- technically I'm not allowed to use the word expertise as a naturopathic doctor, but we work together. And one of the things I really appreciate in our working dynamic is that Adam has a de prescribing program. So that when patients come in with polypharm, multiple medications that are contributing to, in this case, ED, I can refer them to Adam, who will do analysis and a review of their medications and put together recommendations because that falls outside of my scope. And so in that
Mhm.
sense, we offer true collaboration within the clinic. So in this case, I mean, you can read through my side, but I find this is where I really rely and lean into your expertise.
Yeah. So if we had someone coming in where whether it's a prescription drug or illegal drugs or alcohol use, we're going to need to sort of again assess lifestyle and what does the average day look like? Uh, how much alcohol are you drinking? How many drinks per day? If we're getting into, this sounds like a substance use disorder territory, we definitely would refer over to addictions counselor programs or a therapist. If it's just going in a bad direction, but it wouldn't qualify as a substance use disorder yet, this is where we can, again, without having to get alarmed and refer, we can kind of dig in. Okay, again, what are your patterns of using the drug or alcohol? Always sleep. We're always going to look at sleep. And a lot of times people might be self-medicating for stress and sleep using alcohol or other sedatives. And we're going to go through all that lifestyle stuff with them. If we're looking at alcohol, I'll kind of jump here. There are some things like B vitamins and particularly thiamine and a really absorbable form of thiamine or B1 called benfotiamine. And even some probiotics can be quite helpful with, the gut addiction, gut brain connection. So I would actually explore digestion, especially for alcohol, problematic alcohol using. And we can actually work on sort of tapering or deprescribing off of things like alcohol. And then I would work with Yousuf to sort of replace, if we're going to replace a drug, what are we replacing it with? And what was the root cause as to why you were abusing the substance in the first place? Usually there's something there, maybe old trauma, maybe we get a therapist involved. And usually what will happen is I'll sort of clean up the drug mess over here. And then for maintenance, once they're in a better spot, send them back to Yousuf and he does the ongoing treatment plans. If it's certain prescription drugs like benzodiazepines, which are my nemesis in some ways, I do not like those. I don't like that they're still prescribed. Um, we have to taper those slow. So it depends on the individual drug and it's what's called its pharmacokinetics and how it moves out of your system. That's how we would approach. So it's based on the individual patient and the individual drug that we're trying to sort of deprescribe. We'd want to get the prescriber involved. And, some of these meds you need to know that cold turkey is dangerous. And we would start adding some supplements to help sort of replenish them and look at that. And then I would work with Yusuf for the plan moving forward once this drug is removed.
Mhm.
So I know we're running a little short on time. We're almost done the slides, but we wanted to touch on sort of our andropause zone and sort of our classic andropause.
Mhm. So, thanks, Adam, for all that information. Really appreciate it. And it's so important that we look at all the different contributing factors that affect testosterone. This information in this slide, we did talk about it earlier, so I'm going to move through it really
Yeah.
quickly, but it's just a reminder that testosterone levels continually drop and that low testosterone can contribute to central obesity, type 2 diabetes, insulin resistance, arteriosclerosis, hypertension, everything that's listed in there. But there's also this kind of cyclical effect that can also happen with it as well, meaning that if you're overweight, your testosterone levels will be lower. We also see there's a question about testosterone increasing, low testosterone increasing the risk of diabetes. And the type 2 diabetes is often associated with insulin resistance. Again, it's in the same space where type 2 diabetes is generalized to having some level of central obesity. So belly fat, and belly fat carries a lot of aromatase. Aromatase increases the conversion of testosterone to estrogen, and then estrogen has a negative feedback loop to your hormone cascade and will lower testosterone. There's also some interesting studies that say that men with type 2 diabetes are about 2 to 3 more times likely to have lower testosterone than compared to men without testosterone, without diabetes.
Mm.
So it is. So again, it just goes back to that multifactorial space as well.
And did you want to go
Um,
into your approach here of sort of classic andropause with men,
and
Yousuf, and then
again,
I'll do
it's,
mine?
yeah,
Yeah.
absolutely. Thank you. And so like my approach, it's a little bit, I hopefully it's not too confusing, but it's what I'm trying to convey, and I'm going to sound like a broken record. And as naturopaths, we're trying to get to the root cause where it's individualized medicine. We do have some levels of standard of care, but really we're trying to figure out what's going on with a person. And so when testosterone is low, there's herbs that we use to increase testosterone. I think it's also interesting that increased sexual activity increases the amount of testosterone that we're making. It's important as we're aging, so as we're moving into our 50s, 60s, that we're looking at our prostate health, including dihydrotestosterone and estradiol, and the effects that that has on both our prostate, but then on our free testosterone as well as our total testosterone. And so there's herbs really well researched to lower dihydrotestosterone, saw palmetto, rye pollen extract, lycopene, which is cooked tomatoes, stinging nettle, free plant sterols, which also has a benefit in lowering cholesterol, selenium, P5P, so B6, zinc, and your vitamin E. It's also important reminder as men, as we age, is to stay engaged with our strength training. There's a really good study that came out that said that if you can increase the diameter of your quadriceps, testosterone increases. And again, I'm terrible with numbers. It's a thing. And but it increases testosterone levels, and I've seen that actually in practice. Cardiovascular for andropause, again, we are increasing endurance with workouts that vasodilate, so it increases blood flow to penis, but it also decreases adipose tissue fat cells, which then keeps testosterone as testosterone. And again, the metabolic profile. So prioritizing sleep. If you do have sleep apnea, number one is we get you on CPAP or some sort of an oral appliance. Tracking your macros. A lot of guys think they're eating enough protein, but they're actually not. And they're fat and carb loading. So they're moving themselves away from an anabolic state. Avoid alcohol. Again, as we get older, the amount of responsibilities grow and we start to get lost in our responsibilities, feeling overwhelmed. So, really, that stress management piece, because it plays such an integral role in how we show up for ourselves.
Mhm.
And then again, increasing antioxidants, free radicals. That's really that anti-aging longevity space.
Mm. Yeah, no, that sounds great. And I think there's overlap here. And on the sort of pharmacist side, I would also look into all the lifestyle stuff we've been discussing. Again, bit of a broken record, but it's so foundational. You guys can hopefully see that it's first line every time for a naturopathic doctor and a pharmacist. What's the sleep? What's the stress? Even at this stage of life in andropause, where we're looking at, it's sort of somewhat natural and there's variance. Not all guys get this drop. Some guys are, Yusuf and I were saying, some guys are
Mhm.
80 and they aren't really, if you looked at their levels, you wouldn't say this guy's an andropause and they've never had erectile dysfunction. So we're speaking in generalities here, but
Mhm.
in general, we've always got to look at that assessment of lifestyle, get those foundational things in place. But in andropause, guys 40, 50 years old, we've got the testing is indeed low. Lifestyle's pretty good. This is where we could jump to TRT, either in a transdermal cream or IM cypionate or testosterone enanthate once or twice weekly, as we talked about. So this is where on the classic pharmacist side, or even in the pharmacy guidelines, the lifestyle stuff is still acknowledged. Yeah, sure, you could try supplements and all that, but then generally it jumps a bit quicker to sort of gateways open now to, being more not quick, but more open quickly to adding on straight up exogenous testosterone replacement. But there's some important considerations there. You got to look at, like Yusuf was saying, cardiovascular health. So a large amount of visceral body fat, increased aromatase, increased estrogen actually causes problems. So if a guy's coming in and he's very overweight, even if he could qualify for all of, for maybe trying TRT, probably going to need to lose some weight first and get the metabolic health better. Otherwise, it's got a lot more risks. Same thing with blood sugar or diabetes. Is there prostate involvement? Are we looking at benign prostatic hyperplasia, which is basically just like overgrowth of the prostate? And is there elevated DHT? That's something we have to consider as well. And then psychosocial factors, right? Is there high cortisol that might, this guy might be that age of andropause, but it could be cortisol, as we said, that is actually just not letting his free testosterone do his thing. So we need to look at that and correct that first. And how are things in the relationship with a romantic partner?
Adam, I'd love to add to that really quickly.
Please.
It's such an important um, piece that you're talking about. Because I agree, adding in TRT is such a game changer for so many men. And in my practice, I have two nurse practitioners that I refer to. Um, where do I want to go with this? Because it's a little, in these spaces where there are these men's health clinics where they're attempting to hit testosterone values, serum values that are insane. What ends
Mhm.
up happening is you have these men that are coming in with crazy high testosterone, then they're on some sort of an aromatase inhibitor. Now they're on to block the estrogen. Now they're on a like dutasteride or finasteride to drop their dihydrotestosterone. And the same thing that happens in pharmaceuticals, we call a polypharm, happens now in hormone
Yeah.
replacement therapy.
Yeah.
So my approach and the nurse practitioners that I work with, because I'm all for TRT. If my medicine isn't strong enough to get your testosterone to make more your testicles to make more testosterone, let's add it in, but let's do
Mhm.
it safely.
Yeah.
Let's do it in a way where their polyfarm isn't happening. And this is a really important thing in men's health because I
Mhm.
see it in my practice. I have guys that come into my practice, they're getting testosterone from wherever. I'm like, in 6 months, you're going to come knocking on my door and you're like, I feel it in my chest. This is
Yeah.
happening and that's happening. Sure
Yeah.
enough, and 6 months later, they're knocking on my door saying, you're right.
Mhm.
It's
And that's what
it's
you're seeing is what we see, in other areas. It's a prescribing cascade leading to
it's
polypharmacy, right?
wild.
You
It's
take something
wild.
that wasn't correctly prescribed, now you're treating the side effects from that drug with more drugs, and we watch them pile
Wild.
up. Yeah.
And no one, and I say this to every guy when we start TRT prescribed by another practitioner, is no male feels bad on testosterone. We will start this, and you're gonna want more and more and more until you start getting all these side effects. So I
Mhm.
just want to table that I'm all for TRT when it's done safely.
Yeah, yeah, TRT is life-changing for some men, but you got to do it properly. A lot of what's being promoted out there online or some of these, clinics, I'll put in quotes, that's like testosterone abuse. Like that is, you're getting into the bodybuilding, machismo world of testosterone, which can be pretty dangerous.
Yeah. This would be me. Erectile dysfunction. So this would form a decent part of my practice. This is when we look at like restricted blood flow to the penis. Erectile dysfunction becomes more common. About 40% of men experience some degree of erectile dysfunction by the age of 40, and then prevalence rises to about 70 by the age of 70. Complete erectile dysfunction, so the inability to get an erection, only affects about 5% of men around the age of 40 and 15 by the age of 70. Most men coming into my practice are able to get an erection, even if it's a partial erection. They might struggle to maintain it. The andropause connection, called male menopause, which I think most men don't like to hear, refers to the gradual decline in testosterone levels. And, this is when we start to see shifts in libido and quality of erections as well. Yeah. And so it plays an important role. And erectile dysfunction in itself brings men into my practice, and what it does is it opens a wider discussion into what exactly is going on in their body. The guy's thinking, my dick's not hard, but what I'm thinking about is, well, what are all the compounding factors that are contributing to this? It's not always just testosterone.
Mm.
And that takes us, I think, to the next slide, which is
Yeah,
where we
well,
talk about classic ED. So as I mentioned a second ago, testosterone, estradiol, dihydrotestosterone, cortisol all need to be rebalanced in most men over the age of 50, 55, and that's why we run the blood work. And again, referencing the previous andropause slide, I work with these guys to optimize their hormones safely, even if that requires a referral to a nurse practitioner to put them onto TRT. I just want the best result. It's also important to note in my training as a pelvic floor therapist that our Kegel strength in men as we age, and women for that matter, it decreases. And when we have a hypotonic pelvic floor, our ability to lock in the blood into our penis decreases too. There can also be hypertonic pelvic floor, which restricts blood flow. So it's important to have these things assessed. Again, back to the quadriceps and then the herbs for for BPH, which is benign prostatic hyperplasia, enlargement of your prostate, and the estradiol, cardiovascular, training, hawthorn, more than nitric oxide, vasodilators like beetroot, L-arginine is one of my favorites. Picana gel, which is white pine bark, is excellent. And I do like the PDE5s. I find that they're helpful in some men. Trimix for me is a meh. I feel like there's way
Yep.
more options for us to explore first. And for me, that's an absolute last resort. And
Mhm.
normally that's just with men who've had their prostates removed or a major trauma. Again,
Mhm.
mental health, relationship counseling, really important. And then back to that metabolic, diabetes. I love berberine, weight loss, decrease
Mhm.
alcohol and stress management.
Mhm. Well, thanks, Yusuf. That's great. I like your approach. Over on the pharmacy side, yet again, every single slide, copy and pasted. We're gonna look at that lifestyle. And I think Yusuf and I align there across the board.
Mm,
Um, First line, especially if it's not full erectile dysfunction, and we can still at least get a partial erection, you don't have to jump right to the PDE5 inhibitor. So this is where I've had men that maybe aren't ready to take the jump to some of these meds, and it's not necessary, and that's where we can use our arginine or our citrulline or something like beetroot, which are basically like PDE5 inhibitors light. PDE5 inhibitors ultimately do increase nitric oxide. These amino acids just sort of do it at a milder level. So they're just almost like low dose or mild versions of those. We can try those first. If not, again, very safe to try PDE5 inhibitors. But if we get up into max dose of PDE5 inhibitors and we're still not getting the effect, and the lifestyle stuff is essentially, mostly seems to be in place, in these extreme cases, like you said, Yusuf, where it's very resistant ED, or there's been an injury to the area, like we work with a lot of guys that have maybe dealt with prostate cancer, trauma in like post-prostate cancer, trauma to the area. We have a few patients where they've had like motor vehicle accidents or motorcycle accidents where the pelvis has been basically shattered and they've had issues there. So they have blood flow issues ongoing. So more of severe injuries or very resistant ED in andropause. This is where we do compound this last line for a lot of guys. And you are correct that it is last line, but it works and it doesn't require as much of the psychological part. It will cause an erection directly, but it's an intracavernosal injection. So there's a lot of counseling with patients. There's a bit of an art to it. And it will basically, there's a whole range of potencies and strengths, but it does work very well. And it's a direct vasodilator at one level metabolically, basically below the PED5s. So if the PDE5s run out of efficacy, we get to a max dose. Then we move into trimixes and we go to more and more potent and higher doses there. And that can be a great last line for guys that have kind of run out of options and they can still have a sex life. But
mhm,
they're sterile compounded, they're injections, and there is a learning curve for guys to learn how to use these, and they're a lot more involved than other things. So I agree, they are last line, but they're a lifesaver for some of these guys that thought they would never be able to have sex again.
mm.
Okay, we're going to get to the questions and comments. I just wanted to give a quick wrap up message to everybody, and then we've got a few good questions here. So just to wrap everything up and sort of put a bow on everything and summarize, testosterone is vital to men's health, but it is not the end goal. For many men, taking exogenous testosterone TRT is not necessary for healthy T levels and optimal overall health. Men should think beyond testosterone. There's the name of the webinar. And tonight, I hope we've really showcased many options for men's health that lead up to and complement taking exogenous testosterone replacement. And if it's used appropriately, TRT can also be life-changing for many men. And if you're interested about men's health and testosterone, come on in and talk to us here at Nutrigem. So that concludes the webinar, and we'll just jump over. We got a few questions here. I have a good one for you, Yousuf,
Okay.
from Josh B.
Hmm.
His question is, and I don't know if there's a guideline on this, but I wanted to pick your brain. What body fat percentage do you need to be under for it to be safe to do TRT, would you say?
Yeah, it's a great, this brings up the question of I'm gonna do a long-winded answer and then get to the point.
Mhm.
Um, when we look at TRT dosing in someone who is has low testosterone, they don't necessarily have the energy or the willpower to exercise, motivation to make dietary changes. So by almost microdosing testosterone, it increases motivation, increases muscle mass, and starts to correct a deficiency, which increases capacity for weight loss. So
Mm,
it really depends on the person's percent body fat mass. Typically, um, I mean, like it's cautionary when we're starting to get to 30 plus percent. And that's when we're really looking at cardiovascular risk markers. We're really honing in on the conversion of testosterone through aromatase to estrogen as well as to dihydrotestosterone.
mhm,
So for me, it's not necessarily, a lack of testosterone can be a barrier for health optimization. And so it's really just monitoring and adjusting.
mhm. So
That
start low, go slow, and monitor. Basically,
exactly.
there's no hard rule, but I agree. If it's getting up to very high body fat percent, it starts to become a little more, let's maybe try some other things first.
Or we do like conservative dosing of TRT and we
Mhm.
leverage that hormone and make small steps forward. It just depends
Mm.
on the individual's percent body fat. Yeah.
Great. Thank you. Another one. Is it bad? This one's for me. Is it bad to combine those amphetamines with ED meds like Viagra? It's a great question. I
Hmm.
wouldn't say it's bad. We do have men, as I said, that have, ADHD, that do find as a side effect, they do have some erectile dysfunction as a side effect from that medication. They can use things like Viagra or Cialis. It's actually like becoming more common. This is sort of like a prescribing cascade, like Dr. Yusuf was talking about. But they are okay to use together. There's no significant interactions. You are playing a bit of a vasoconstriction, vasodilation back and forth game a little bit. But in general, they can be used together, and I've never seen anything really unsafe from it. Um, so yeah, it could get dangerous with high doses of both. For example, because I think there your blood vessels basically dilating versus constricting becomes unpredictable. But it's not uncommon to see those two used together, and I've never, in theory, they're fine interaction wise, and I've never seen an actual like clinical problem or a side effect or something dangerous happen from it. So I would say yes, they're fine to use together. Yeah.
And clinically, as a naturopathic doctor, where both of those fall outside of my scope, but clinically, I have patients who take both.
Yeah.
Sometimes there will be a tightness in the chest
Yeah.
that can exist, and what some of my male patients will do um, is they'll pause the stimulant on the weekends, and it just
Mhm.
gives them a bit of a break and allows
Yeah.
them to be more connected into their libido and sexual relationships.
And the other thing too is, yes, they can be taken together, but what you'll find is if you took a break and took, Viagra, for example, a lower dose would really give you a big effect if you weren't taking those stimulants. Well, a lot of these guys
Mhm.
have to get up to higher doses of Viagra or Cialis to sort of overpower the effect of those stimulants, which is fine. And like you said, they might get a little tightness in the chest.
Yeah.
Sometimes like weird flushing effects, which happens with PD-5 inhibitors anyway. But what I would say is they're fine to take together, but you might need a bigger dose of the PD-5 inhibitor while you're on the stimulant compared to if you weren't, just to sort of override that effect. Yeah.
Hmm.
Um,
What are
you
some of
know,
the best exercises for pelvic floor strength?
yeah,
That's a great
that's
question.
very you, Yousuf.
That's a me
Yes,
question.
it's the most Yousuf
And,
question.
and you're going to get a Yusuf answer, which probably is not. But you're hoping I'm going to say do some crunches and Kegels. I'd say, pelvic floor is really interesting, I have to say, in the sense that even as a clinician, when I think it's one thing, it ends up being something completely different. So it's a really interesting space. So the pelvic floor are all the muscles that form the inside of your pelvis. There's a few key ones, your ischio and your bulbo, that actually move internally and form the shaft of your penis. And what our Kegels are is a collection of these muscles that allow us to hold our urine. They help with the ejaculatory response. Um, so what are the key exercises to do? I mean, it depends on exactly where the misalignment is. So if you're looking at like a generalized Kegel and a way to assess your Kegel strength at home, what one of the things you can do, and this is going to sound kind of funny, is you stand in front of a mirror nude, and so pelvic floor therapy is taught by it's mostly geared towards women for obvious reasons, and in the studies, I'm really pushing the evolution for it in terms of men's health. The verbiage that we use or the cues that we're supposed to tell our patients is imagine the train pulling into the station as a way of visualizing pulling your penis inward. I'm like, what man is going to want to say that or think that? That's a terrible idea. But the idea is like it's the contraction of the muscles and the tissue that you use to stop peeing. So when you're standing in front of a mirror nude, you should see your penis lift and your testicles lift. If you're not seeing that movement, then we know that you more than likely have a hypotonic, and that's when that classic Kegel exercises kick in. So that's where you're learning diaphragmatic breathing. As you're breathing out, you're contracting from your perineum up, and that's quite helpful. On the flip side, if you stand in front of a mirror and you do that verbal contraction and you see everything lift, and then when you release, it stays lifted, that's when you have a hypertonic pelvic floor, and then Kegels are actually contraindicated. So that's a good home test to do because it'll give you really quick data as to what exactly is going on. And then if you can contract and hold it for 10 seconds and let go and everything falls back to normal, probably not a Kegel issue.
Mm, interesting.
Interesting, right?
Great. Yeah.
And I was
Cool.
gonna go home and be like, or go to their bathroom and be like,
Yeah. That's hilarious. I think I got one more question here. This one's for me.
"Mhm."
It's what are the would the benefits of cannabis to potentially reduce cortisol and stress outweigh the costs of the other health impacts? So again, I mentioned cannabis, and I'm a proponent of cannabis, and when you can use it appropriately, and I work with medical cannabis here at Nutrichem, and it's a very useful tool in the toolbox, in particular, for like pain, anxiety, and sleep. Partly because it's useful and has a good safety profile in those areas. And frankly, the pharmaceuticals available in those areas are pretty dangerous, can cause tolerance and dependence, right? Pain, we know there's an opioid crisis. Anxiety, benzodiazepines cause dependence and tolerance, and they stop working for a lot of people. And sleeping pills are basically just versions of benzos, or they just use straight benzos. So all of those medications are pretty suboptimal, I would say. And there hasn't been a big evolution in those areas. Cannabis can be really useful, and it can the benefits of it can outweigh it, especially when we're sort of on this medical side where I see as much as I can do with CBD, in particular like oils. I get patients away from smoking and sort of the harm reduction and cardiovascular problems. We don't want extreme use, so sometimes you get these people who are very heavy cannabis users and they're big proponents of cannabis. They don't realize like smoking joints all day can actually cause a lot of problems cardiovascularly, even mood wise. Like, these are the patients we've got to move them away from sort of this stoner lifestyle. They're kind of self-medicating and shift them over to edibles, not smoking, lower dosing, not being stoned all throughout the day, that's where I would say the risks outweigh the benefits. But if you're someone that needs, a small amount of cannabis in the evening to sort of wind down and relax, you're using it in moderation that way, and it does help you relax, then yes, I'm a big proponent of cannabis. It's just the overuse of cannabis, the smoking of cannabis that becomes a problem. So that would be so yes, the benefits of cannabis can outweigh the risks via like stress reduction and sleep and cortisol, but you have to use it in moderation and safely.
Hmm. And as a naturopath, I mean, it's botanical, and I believe, as Adam is saying, that it's a great option, but it's not the only option too. So I
Again, like
appreciate
testosterone, it's a tool in a toolbox, right? Like people get really
exactly.
set on the magic pill paradigm of, oh, the cannabis is the trick and testosterone's the trick. It's how you use them. They're just tools, right? It's our relationship with them and how we use them effectively that defines whether they're beneficial or risky. Yeah.
Well,
Well,
that seems it for all of our
I think
questions.
that's all of our questions. Thank you all so much. If there's any other questions, let us know. You can reach out to us, and if there's anything, we can get back to you via email. And I think there was some other questions as to whether or not the slides would be sent out. We will send those out in the next couple of days for anyone that was registered.
And
Otherwise,
there'll
yeah,
be a survey that comes out post after the webinar, and we'd really appreciate it if you were to complete the survey because it gives us just some information regarding how it went and just some data collection that we're looking for as well. So we appreciate it. Thanks for listening, everybody.
That was great. Thank you guys.
awesome. Well, thank you all very much. Have a great evening, and we hope to see you soon. Come on into NutriChem and chat with us. Bye bye.
Have a good one.